So peripheral T-cell lymphomas are blood cancers arising out of lymphocytes, and particularly arising out of T lymphocytes that have matured out of the thymus. So they're also called mature T-cell lymphomas. They're called peripheral T-cell lymphomas because these T cells sort of inhabit our peripheral organs like the liver, spleen, bone marrow, etc., and the lymph nodes, of course. So the whole group of malignancies that arises from these T cells that have gone malignant are called peripheral T-cell lymphomas. And PTCL NOS is one subtype of peripheral T-cell lymphoma. And you make this diagnosis based on, obviously, the microscopic examination of the tumor that the patient has, as well as some specialized testing like looking at the surface proteins by immunohistochemistry, flow cytometry. And so there are specific findings for these different subgroups of T-cell lymphoma. There are about 30 different subtypes of peripheral T-cell lymphomas that we deal with. And the classification continues to increase as we have better understanding of these diseases and their heterogeneity. The symptoms are what a patient with lymphoma will experience, very similar except there are a few distinguishing features sometimes. They can have fevers, they can have night sweats. Of course, they can always have enlarged lymph nodes. That's one of the common presentations. They can have elevated blood count because this can spill over into the blood as well. Sometimes they have skin rashes that actually are either directly as a result of having the lymphoma going into the skin or as a result of some of the reactions to the lymphoma. So itching, rashes, you can also have weight loss, which is another big one. Patients with peripheral T-cell lymphoma are pretty sick. Usually these are aggressive tumors. So the symptoms are usually pretty dramatic. The diagnosis is based on the examination of the tumor, and initially you need a good biopsy. A lot of times a biopsy is done with what's called a fine needle aspirate, which is just some liquid aspirated from a tumor site, which is not enough to make a diagnosis. You really need the full architecture of the tumor to really make a correct diagnosis and to subtype the malignancy properly. So once you get a biopsy, it is then evaluated under the microscope by the hematopathologist, and then they do special testing on it. They look for the surface expression of proteins on the malignant cells by staining and then by flow cytometry. And nowadays they also do molecular testing on the tumor to look for what's called clonality. That is based on testing what's called T-cell receptor, which is one of the proteins expressed or one of the molecules expressed on the surface of the malignant T-cell. And they can distinguish that from just a reactive collection of T-cells. So that's clonality testing. And then they also look for mutation analysis to try to figure out what genetic abnormalities the tumor may have, which sometimes helps us direct therapies as well. So the diagnosis is pretty complicated sometimes, and you'd really need experts who know what they're dealing with and who are experts in diagnosing T-cell lymphomas, expert hematopathologists. So it's important to get the correct diagnosis and correct subtype of the peripheral T-cell lymphoma. Right now, we have some standard treatments that are recommended by the NCCN guidelines. If the tumor has expression of something called CD30, or it is a subtype called anaplastic large cell lymphoma, then the recommendation is to do a combination of chemotherapy called CHP with brentuximab vedotin, which is an antibody that is directed against CD30. So for that specific subtype of tumors, we do have good data to support this as the best therapy available at the present time. For other subtypes where the CD30 expression is not either low or absent, the standard treatment is to give something called CHOP chemotherapy or CHOP-based chemotherapy. Sometimes in younger patients, we add a drug called etoposide, called CHOEP. So it becomes CHOEP. So that's recommended, though, we're hoping we can improve the outcomes of these treatments by adding other stuff, but those are in clinical trials right now. The recommendation really is that if you can get to a clinical trial, that is the best option. And we have some studies that are ongoing that are looking at combinations of CHOP. It's a multi-center trial And hopefully that'll give us some data about what the best treatment should be moving forward. But at the moment, those are still in clinical trials. So without a trial, the best option is a CHOP-based treatment, or otherwise try to look for a trial. Absolutely. So that's the whole idea of doing clinical research in this disease. We know there's a huge unmet need in this particular group of diseases. As I mentioned, even upfront treatments are based on empirical treatments borrowed from other types of lymphomas. We don't have specific treatments for T-cell lymphomas in the upfront setting. We hope that we will have better information about that. And then in the relapse setting, again, there are a few approved agents that have low response rates, but we are now looking at novel agents that are being evaluated based on what the molecular findings are in the tumors. For example, if they have a set of mutations or a pathway that's dysregulated called the JAK-STAT pathway, it can be targeted with drugs that inhibit that pathway, like ruxolitinib. Then you have patients who have the PI3 kinase dysregulated. They respond to drugs like PI3 kinase inhibitors. One of the sort of well-studied one in T-cell lymphomas is duvelisib. There is also another very positive trial that has come out of a drug called valametostat. So we're hoping that these agents will be eventually approved for T-cell lymphoma, so they're available to everybody, without having to be on a clinical trial. Novel approaches like CAR T-cells are being developed for T-cell lymphomas. So there's a lot of research going on to look for new agents.